All right, here is part 2 of the ACS lecture. Just want to make sure that I was clear for the STEMI slide. You can see again those Roman numerals 1, 2, and 3 on that left-hand column. Then there's a second column. It's the second out of 4 columns with AVR on the first line. The second line is AVL. This third line is AVF. Then that third column, right kind of in the middle, it says V1, then below that is V2, then V3, and then that final column is V4, V5, V6. Again, notice at the top that it says acute MI suspected. So even if you have no idea what any of these lines mean, if you ever get an EKG that says acute MI suspected, you probably should tell somebody and get some help. Okay, it also says ST elevation, consider inferiolateral injury or acute infarct. So it's telling you that there's some ST elevation here on this EKG on that right column there at the top. So important to know for STEMIs, it is an emergency. We have to act quickly to limit the infarct size, so to limit the damage size. We have to open the artery that's affected within 90 minutes of presentation to the healthcare facility to restore blood flow and therefore oxygen to the heart muscle. Otherwise, we run the risk of this infarct becoming permanent. So the way that we do this is through PCI or thrombolytic therapy. So PCI is a heart catheterization where they go in and open up the vessel manually. And then thrombolytic therapy is where they give thrombolytics or fibrinolytics to bust up a clot. So the gold standard is PCI. If you do not have access to PCI, then we would do fibrinolytic therapy. Complications to watch out for STEMI. So think about we are affecting the function of the wall of the heart, okay? So it makes sense like things like heart failure would result because their heart muscle is not going to work effectively anymore. They can have dysrhythmias because whenever the muscle of the heart is damaged, the electrical activity can't flow through the heart like it should. You can have cardiogenic shock, again, because you're not having cardiac output like you should. And there are other complications that you should look for, but those are the biggies. So moving on, we already saw Kermit. So this is just to further explain the patterns of a STEMI on an EKG. You are not responsible for knowing this, but depending on which coronary artery is affected, there are certain patterns that show up on the EKG. So certain of those blocks will have ST elevation or ST depression, depending on which artery is blocked. So when they go in to do PCI, they know where to start because of the pattern that shows up on the EKG. Again, this is not anything that you're responsible for, it's just informational. Okay, so what is PCI? So it's angiography, so that's like the lighting up of things so we can see what's blocked. And then the cardiac catheterization is where they go in and open up the blocked area. Okay, so they stick this catheter up into the coronary arteries, and then they can open them up. So they can go in there and see if there's a blockage and how bad it is. People with unstable angina by themselves visit to the cath lab, okay? A cath lab is where they do this cardiac catheterization with PCI, okay? So unstable angina, and you have to have some EKG changes because that shows that you're having damage to, or issues with oxygen and blood flow to that area of the heart, right? With potential damage to the tissue. So if you don't have EKG changes, then we might admit you, do some serial troponins, do some serial EKGs, and see if we get EKG changes, and then we would do a cath lab, or we would do a stress test, but we'll talk about that in a second. So PCI stands for percutaneous coronary intervention. So they can go in there and they can either kind of roto-rooter the vessel, and then, or they take a balloon and kind of push that plaqued area open. They put a stent in there. If you cannot do a cardiac catheterization, you have to do a CABG. So a CABG would be like an open heart surgery to open the valves, okay? circling back, EKG changes we would be looking for would be T-wave inversion, ST elevation, or ST depression. Make sure to read in your ATI book the complications post-procedure. Okay, that is something that you're going to be tested on. So make sure to read up on the procedural notes around that in that purple ATI book. So just to give you a preview, things like bleeding, thrombosis, arrhythmias, recurrent chest pain could all be complications. And then after these procedures, what they do is they thread a catheter in through the femoral artery. So you want to check the neurovascular status of that extremity, whatever one they used. You want to check the site. You're going to do EKGs, especially if the patient complains of any chest pain. And then your client is going to be on bed rest. Usually it's 6 hours. So let's show you what happens. So this is a before and after. A is before, B is after. So if you see where that arrow is pointing, below there should be a dark line, and it's totally black, or totally like opaque. So there's no blood flow going past that little narrowed section right there where the arrow is pointing. And then if you look over at B, a whole vessel shows up where there wasn't one before. So that is a whole area of the heart that's now got restored blood flow. So it's pretty dramatic what they can do with opening up these coronary arteries and restoring some oxygenation to those tissues. And it makes sense that the sooner we can get that done, the better the outcomes are for the client. Alrighty, moving right along. Okay, back to our friend MP. So while awaiting diagnostic testing for MP, what drug would you expect the healthcare provider to prescribe for MP to use if he develops indigestion the next time he mows the lawn? So remember, what is the medication that we give for stable angina? Nitro, right? We want to see if that nitro makes a difference. And then what kind of diagnostics do you think we would do? So remember, our patient's got stable angina. So he doesn't have unstable angina because that with EKG changes, because that would send him to the cath lab, right? But he's got stable angina. So what we would do is a stress test, because that allows us to kind of poke the bear, see if we can recreate the situation where the patient would experience their chest pain or their shortness of breath or whatever they came in with. And then if they do have a positive stress test, so you do have an instance where they do get short of breath or do have chest pain or dizziness or whatever, then they would go get a cath lab visit to do PCI, okay? Because that's demonstrating that they have some significant enough issues that you've got to go intervene. All right, so MP's chest x-ray and ECG results are all within normal limits. His cholesterol and triglyceride levels are elevated, which we're not surprised by. He does develop some chest pain and SD segment depression during an exercise stress test. So our friend, we went in, he didn't have anything really clear to say that he was having a nasty heart attack, but when we did this stress test, he did have some EKG changes and did experience some chest pain. So at this point, he would buy himself a visit to the cath lab to do PCI, okay? And see if he's got any significant enough blockages that they need to intervene on. All right, so I think you guys have covered these in pharmacology, but we're gonna review them quickly, okay? So these are the medications that we give when somebody comes in with experience of chest pain, okay? Vasodilators, so that's your nitroglycerin. We're going to give it 3 times, 5 minutes apart. So remember what you're watching for with the nitro is it's going to give your patient a headache, right? Its job is to dilate all the blood vessels, including the ones in the brain. So they will get a headache. Warn your patient ahead of time. But the goal is to get rid of chest pain, okay? So if your patient still has chest pain, you're going to do these recurrent nitroglycerins. If the pain is gone after one, then you do not have to give the other ones. You're also going to make sure that they don't bottom out their blood pressure too much. Okay, so if they have a significant enough drop in pressure, you would want to tell your healthcare provider and be like, hey, do you want us to give the subsequent ones because their blood pressure is fill in the blank. Now, morphine kind of does a double duty. It does handle pain, but it also decreases the myocardial oxygen consumption. So not only is it pain medicine, but it helps the heart not have to work so hard, okay? Beta blockers like metoprolol, they prevent arrhythmias. They do help with hypertension. They decrease this imbalance between supply and demand by affecting the afterload, and it slows the heart rate. So your beta blockers are doing lots of jobs as well. Thrombolytics. So thrombolytics jobs are to break up clots. So the idea is to get these on board within 6 hours of the infarct. There are contraindications for thrombolytics. This will come into play not only with STEMI, but when we start talking about stroke. So if your patient has any active bleeding, if they've got peptic ulcer disease, they have a history of a stroke or recent trauma. And thrombolytics are only for STEMIs. They're available for those that don't have access to cath lab. It does limit the size of the infarct by dissolving the thrombus and helps that muscle get perfusion again. The goal is to administer these thrombolytics within 30 minutes of their arrival to the facility. And then you've got things like aspirin and clopidogrel, Plavix. Aspirin prevents platelets from forming clots, but it also prevents vasoconstriction. So when you pair aspirin with nitro, nitro's job is to dilate everything, right? And then aspirin's job is to prevent vasoconstriction. So they kind of work in tandem with each other to help open up these vessels, okay? So that's why your aspirin is included in your ONAM as one of your priority interventions. So not only is it going to keep things from getting worse, it's going to help dilate those vessels, okay? And then heparin and Lovenox, enoxaparin, they prevent the clots from becoming larger or creating any new clots. So medications are very important, and one of the main things that we use to help our patients who are experiencing MIs. All right, back to our friend MP. He undergoes his cardiac catheterization. There's a 90% occlusion of his right coronary artery. They put in a balloon and open it up, put a stent in the place where that blockage was. We give him some discharge teaching, talk about lifestyle changes like diet and exercise, and then he's going to follow up with his doctor. It is very, very, very important that you understand discharge teaching for acute coronary syndrome. You will be tested on it. You need to know it. Make sure you're very comfortable with what kind of discharge teaching you would give your patient. Okay, so go look that up. You're responsible for knowing it. Because of this, so 6 months later, MP arrives to the ER with severe immobilizing chest pain radiating down his left arm. Okay, so that's very different than the indigestion he was feeling mowing the lawn, right? He admits to not following his healthcare provider's advice related to diet and exercise. He thought that we fixed it all for him. When we put that stent in, the ER physicians expects acute coronary syndrome. Again, because he's got this immobilizing chest pain radiating down the left arm. He's got a history of a previous stent placement. He's got all these nasty risk factors, right? So what would be our priority interventions for him? So remember, priorities are the priority. So we have to get an EKG, right? Because that tells us if we're dealing with significant blockage or not. So we got to get the EKG done. Then we want to do our ONAM. Throw some oxygen on him really fast. It takes just a second. We're going to give nitro to see if we can relieve that chest pain. We're going to give the chewable aspirin. And then, and remember, aspirin here is not for pain relief. Aspirin here is to prevent the vasoconstriction and to prevent platelet aggregation, okay? Sometimes students get confused and think we're giving it for pain. We're not. It might help, I guess, a little bit, but that's not the goal with the aspirin here, okay? And then we're gonna, if the nitros don't work, then we would give morphine for pain. So that's our ONAM. Okay, we're also going to do probably a chest x-ray. We're going to draw some lab work, including that troponin level, because we need that troponin level to help us determine the difference between unstable angina and then moving on into an NSTEMI, right, or a STEMI. Because if we have changes in the labs, remember that's that transition from angina into MI, if you remember our $1 million slide from before. Okay, I think we hit most of them. So MP's EKG shows significant ST elevation, so we have a STEMI, right? What do you think we were going to do for our friend within 90 minutes of his arrival to the ED? He needs a heart cath, right? Because we've got to go in and open up those vessels. All right, so that is the end of the lecture portion. I've got one more joke for you guys. Just thought this was really cute. I do have a case study that we're going to do on Thursday. And it's from I think it's from a book that I have. I don't know that you guys have access to it. So I will have slides for you guys that we're going to go over together. Bring any questions you have. We will go over ACLS algorithms, which is advanced cardiac life support algorithms. So just to kind of refresh and review what to do for somebody who's expected for a myocardial infarction. There's a whole like algorithm that you follow, kind of like a if this then that kind of a thing. And yeah, we'll probably look at EKGs again just for fun to make sure that you guys understand that. Otherwise, I hope that you guys are doing well, and I will talk to you on Thursday.